My name is Dr. Gail Roboz. I'm a professor of medicine and director of the Clinical and Translational Leukemia Program at Weill Cornell Medicine and the New York Presbyterian Hospital in New York City. I've been asked today to talk for a minute about adding targeted agents to induction therapy for acute myeloid leukemia. So induction therapy for AML is designed to get patients into remission. Remission is defined as normal blood counts in the setting of fewer than 5% blasts in the marrow. And historically, induction regimens have been divided into patients who could and could not receive intensive chemotherapy based on lots of different clinical factors, least important of which is actually chronological age, but rather their overall performance status, comorbidities, laboratory tests, et cetera. So if you were getting intensive chemotherapy, you were typically getting a regimen based on cytarabine and an anthracycline. And if you were getting a non-intensive regimen, you were getting either low-dose cytarabine or one of the hypomethylating agents. And in the last several years, there's really been a question of what type of bells and whistles or what type of additional targeted agents could be added on to either a non-intensive or an intensive backbone to optimize the probability of a successful induction. And there are several agents that fall into this category. With respect to an intensive backbone, we know now that the standard of care is to add, for FLT3 mutated patients, to add a FLT3 inhibitor. In the United States, we have midostaurin approved for addition to classic 7+3 induction for patients with a FLT3 mutation. And there are ongoing trials looking at next generation FLT3 inhibitors to see if these can also be of benefit when added to intensive chemotherapy. The targeted antibody gemtuzumab ozogamicin hits CD33, and the addition of this agent to intensive 7+3 type of background has been shown to improve event-free survival and has a particular benefit in the ELN favorable risk category, especially core binding factor leukemia, where there is quite a dramatic effect from the addition of gemtuzumab to standard chemotherapy. Now, targeting is an interesting concept because we think of targets more recently as mutational targets like FLT3, but it's important to keep in mind things like gemtuzumab, for example, which do have a target of CD33. And also the BCL2 inhibitor venetoclax is a targeted agent, again, against BCL2. And the addition of venetoclax to a lower intensity backbone of either a hypomethylating agent or low-dose cytarabine has really transformed the standard of care for older patients or those who are not in condition to receive intensive chemotherapy. The addition of venetoclax to azacitidine in the VIALI-A trial has shown to have a significant survival benefit and is approved in the United States and hopefully will be elsewhere in the world as well, because the overall rates of complete remission and survival are much higher than when you would use a hypomethylating agent or low-dose cytarabine alone. Now, what other targets can we talk about? Well, we have one target that's important is the IDH mutations, both IDH1 and IDH2. These have designated targeted inhibitors, ivosidenib for IDH1 and enasidenib for IDH2. And there are ongoing trials actually looking to see whether these inhibitors would have an incremental benefit when added to standard chemotherapy. There are also emerging data about the addition of these inhibitors to hypomethylating agents. And I would say that the jury is not completely out yet about how to optimize the combination of IDH inhibitors with hypomethylating agents. But these drugs can also be used on their own. The response rates are lower when they are used as single agents for IDH mutated disease in the upfront setting, but they can be considered. And of course, their approvals are in the relapse setting, with ivosidenib actually having a separate indication as a single agent for newly diagnosed, more frail patients with AML. But I think it's interesting to note that an IDH inhibitor, of course, is targeting IDH. But for example, if you look at the rates of success of venetoclax, both with FLT3 mutated patients and more especially with IDH mutated patients for whom venetoclax in combination with hypomethylating agents has very high rates of response. Again, the targeting here is to presumably BCL2, but does have an extremely strong beneficial effect for IDH mutants. So I would say a little bit of mixing and matching there. New generation drugs, FLT3 inhibitors, for example, like gilteritinib, are being explored in combinations both with hypomethylating agents and with intensive chemotherapy. And of course, this is when one gets into doublets and triplets, and can you combine chemo plus venetoclax plus one of the IDH inhibitors or plus a FLT3 inhibitor. Don't do this at home yet. We need more clinical trials data, and some of the data that are coming out are actually surprising that just adding on an additional agent may not offer a remission or survival benefit, but many, many new trials are ongoing and highly anticipated. So in summary, the addition of targeted agents, things like FLT3 inhibitors, IDH inhibitors, gemtuzumab, venetoclax, two backbone regimens for induction therapy in AML have transformed the landscape of the disease. We are doing better than we ever were, and we certainly hope to further optimize these results by many, many more important clinical trials. So please do enroll your patients. Thank you for your attention.